Today, we will discuss the state of diabetes in California with healthcare experts, address the work being done in our state assembly with legislators, and introduce you to what issues the Diabetes Patient Advocacy Coalition is focusing on and how you can advocate on these issues with us. Thank you again for attending, and I look forward to seeing you advocate with me in Sacramento someday soon. I'll now hand it over to the Executive Director of the Diabetes Patient Advocacy Coalition, Julie Babbage.
All right, thank you so much, Ed. And on behalf of the Diabetes Patient Advocacy Coalition, thank you to those tuning in to join us. We have an audience here and on Facebook, and we're so excited to have a lot of people on the phone right now representing folks across the diabetes community, type 1, type 2, parents of children, others with connections through family and friends, and we are so excited to have you here with us. I'll get into the agenda for today. We'll kick off with experts in healthcare who can provide deeper insight into the state of diabetes in California. And then we'll bring in our panelists from the California State Legislature, Assemblymember Adrian Nazarian, for a conversation on diabetes issues and the work that he and others are doing. After that, we'll get into the nuts and bolts of advocacy, and we'll talk about the hot topics, the issues that are important to people with diabetes, as well as legislative solutions to them. And we'll wrap it up with next steps, all in just 2 hours. So if we can transition into our first panel, which is the state of diabetes in California. We've got a few slides here that we'll show at the start of the conversation, and then we'll stop sharing them so that our panelists can see each other better. And I'll let our panelists turn on their cameras and their microphones, please. And I will introduce our moderator for this panel, Marissa Town. So Marissa is a nurse and diabetes care and education specialist who has lived with type 1 diabetes for 31 years. She is the clinical director for children with diabetes and a clinical research manager for Stanford University. Marissa has a passion for helping people and families with diabetes and has worked in clinical industry and research settings throughout her career. So thanks so much, Marissa, for joining us today. And I will hand it over to you now to introduce our panelists.
Great, thank you so much, Julie. And I really appreciate you and DPAC and DLC and everything that you guys do for us with diabetes. So I'm going to start with Dr. Steve Edelman. And Dr. Stephen Edelman is a professor of medicine in the Division of Endocrinology, Diabetes, and Metabolism at the University of California, San Diego, California, and the Veterans Affairs Healthcare System of San Diego. He's also the director of the Diabetes Care Clinic at the VA Medical Center. He achieved high honors during his undergrad at University of California, Los Angeles, and was valedictorian of his medical school class at UC Davis Medical School. Dr. Edelman received his internal medicine training at UCLA and completed his endocrinology fellowship at Joslin and Lahey Clinics in Boston, Massachusetts, as well as a research fellowship at UCSD. Dr. Edelman has strong interests in education and patient advocacy. He is the founder and director for Taking Control of Your Diabetes, TCOYD, a nonprofit organization with the goal of teaching and motivating patients in diabetes self-care. Since 1995, TCOYD has reached hundreds of thousands of people living with diabetes through a variety of education portals, including national conferences, publications, television, and community programs. Dr. Edelman has written more than 220 articles and 5 books. He's won numerous awards for teaching and humanitarianism, and he has been chosen as the Teacher of the Year among over 400 faculty members at UCSD numerous times. He was awarded the Diabetes Educator of the Year by the American Diabetes Association in 2009, the Distinction in Endocrinology Award by the American Association of Clinical Endocrinologists in 2011, and was recently named in the US News and World Report as among the top 1% of endocrinologists in the US.
Gosh, there's no time for our program now. Thank you for that nice intro. I wish I would have given you a recent picture, not when I was like 21 years old, but anyway, pleasure to be here. Thank you for that kind introduction, and happy to be on the panel with everyone else.
You're welcome. And the next person that I'm going to introduce is Dr. Priya Prahalad. And I had the pleasure of working with Dr. Prahalad at Stanford and through various projects. And Dr. Prahalad is a clinical assistant professor specializing in pediatric endocrinology at Stanford University in Palo Alto, California. She obtained her BS in biology from the Massachusetts Institute of Technology in Cambridge, Massachusetts, before attending medical school at the Georgetown University in Washington, D.C. Dr. Prahalad received her pediatric medical training at the University of California, San Francisco, where she would go on to complete her fellowship in pediatric endocrinology. Dr. Prahalad has quickly established herself in her field, having authored over 20 publications in the past 5 years. Currently, she's administering clinical trials regarding the remote monitoring of CGM data in pediatric patients with newly diagnosed type 1 diabetes, work that will help pave the future for diabetes care. She maintains an academic membership to the Maternal and Child Health Research Institute at Stanford University. In addition to her strong academic work, Dr. Prahalad still takes time to see patients at the Mary L. Johnson Specialty Services Clinic as part of a pediatric endocrinology care team that is nationally ranked in the field by U.S. News and World Report. Welcome, Dr. Prahalad.
Thank you, Marissa, for the kind words. And I'm very happy to be here today to talk about issues that are really important to us as healthcare providers as well.
Great. And last but certainly not least is Dr. Gary Puckrein. And Dr. Gary Puckrein is the president and the CEO of the National Minority Quality Forum, NMQF, a Washington, D.C. based not-for-profit organization that he founded in 1988. NMQF is a research and educational organization dedicated to ensuring that high-risk racial and ethnic populations and communities receive optimal health care. In furtherance of NMQF's mission to reduce patient risk by assuring optimal care for all, this nonprofit, nonpartisan organization integrates data and expertise in support of initiatives that eliminate health disparities. Under his leadership, NMQF launched the National Health Index, NHI, a comprehensive database that links vital statistics, demographics, benefit claims, healthcare access points, for example, hospitals or physicians' offices, and other data elements into one centralized data warehouse organized around zip codes. The NHI measures and forecasts health status in small geographic areas, evaluates the impact of specific interventions, monitors changes in health outcomes, and undertakes risk assessments. NMQF uses the NHI to provide a common set of indicators to stratify communities by health status. Dr. Puckrein graduated Phi Beta Kappa from Brown University, where he received his doctorate and master's degrees. Prior to NMQF, he achieved tenure as a history professor at Rutgers University. Welcome.
Well, thank you so much. I'm so glad to join you this afternoon. Looking forward to the conversation.
Me as well. So I think we'll get right into it at this point. And, you know, you guys all come from various parts of the countries. And I believe Julie mentioned that there were a couple more slides, but I'm not sure if they're going to show the health index. There it is. I was going to ask if Gary, you'd like to start by talking about this and how it's measured?
Surely. So the National Minority Quality Forum, as you suggested, has been collecting health data for about 20 years. We have a database of over 20 billion patient records. We collect data on about 160 million lives per year, covering 72,000 conditions, and one of them is diabetes. Here, we're looking at diabetes in the Medicare fee-for-service program that we're mapping by zip code, and those color-coded what it's showing is where diabetes is more concentrated in that Fresno area, for example, somewhere almost 27% of the population has diabetes. But the index does something more than that. One of the most important things that our healthcare system does is reduce patient risk. If you think about it for a second, that's really what you want your healthcare system to do. When you go into the healthcare system, be it the hospital or emergency room or wherever you go, what you expect is that the healthcare system is going to lower your risk and give you great outcomes. And what you can see here is that even though California is slightly better than the rest of the country in terms of hospitalizations and ER rates, look at that hospitalization rate for people. 48% of everyone with diabetes in the Medicare fee-for-service program is being hospitalized, right? 61% have had an emergency room visit. That is a complete failure, no question about it. And so the point is, we need to really advocate now. We have to reduce those risks, and we need to have metrics that are patient-centric. Too often, our healthcare system is focused on managing financial risk and forgetting about patient risk. And when we look at patient risk, what we see is they're all going to the hospital, they're all going to the emergency room, and they're costly. And so what we are at the National Minority Quality Forum, we are deeply committed to reducing those rates. We think that hospital and emergency room care is not appropriate care for people living with diabetes.
Yeah, and it, showing that first graphic, one of the things that we know is that about 1 in 10 people have diabetes at this point, and 9.7% of people in California have diabetes in some form. And the other thing with that is the total medical expenses for diagnosed, undiagnosed, pre-diabetes, and even gestational was estimated to cost $27.6 billion in the state of California in 2012. So, even though the focus is on the people and is on prevention, sometimes if the payers want to talk about the money, there's the money that correlates to helping care for better giving patients better care. And yeah, Steve, I see you raising your finger. Would you like to talk sort of about California from your perspective?
I was just going to make a quick comment on Gary's data. Gary, do you remember me?
Oh, absolutely, Steve.
Okay, I was going to say,
yes.
Gary and I worked together on an initiative many years ago.
Absolutely.
We traveled all over the place and looked at diabetes and underserved areas. It was great. The data that you show, it's really upsetting because a lot of these hospital admissions are based on no access to outpatient care. And poor access to the best medications and tools such as glucose meters, continuous glucose monitors. So, it's when you look at how much we spend on this chart, it could be reduced easily in half by proper medical care. And the problem is, Gary said, people, they're short-sighted. They make cutbacks that lead to big expense and end-stage complications. I'll just say a few words about what's happening in California. I'm in two different types of settings. I'm at the Veterans Hospital, I'm at the big university, but I do speak with practitioners around the country now virtually. And what most institutions have switched to video visits or phone visits. The VA is slow in doing the video visits, but we have phone visits and video visits. And of course, there's higher billing for video visits. So they're pushing us to get people on the video. I do think it's worthwhile seeing someone's face. You see them at home. But the bottom line is endocrinology, or at least diabetes care, has not really been hurt to any great extent if you have insurance. It's the people that don't have insurance are the ones that are hurt the most because they don't have access to anybody. And so people in private practice, they're still seeing patients, some of them. They do it as safe they can. They put on the mask. But I do think diabetes is one of these conditions where you don't really need to put your hands on somebody. And there's amazing things you can do. I think Priya's shaking her head because you're a pediatric, correct? So she's happy that the parents are not in her office, but they're sticking their head in on the camera to try to get their kid to say the right thing. But I think that if it's done right, people have made the transition pretty well. So I think there is a silver lining in the fact that I think that after COVID is gone, that there will be a hybrid approach. But once again, we deal every day with people that cannot get the things they need or see a physician that's knowledgeable about diabetes.
Yeah, and Priya, how about you for Northern California?
Yeah, so for Northern California, I primarily see children with diabetes, and California is a really good state for children who have diabetes. For those who are on private insurance, insurances will cover many of the costs, but for a lot of families, it's still quite a stretch. Some of these monthly bills can be in the hundreds of dollars a month. And so we're often faced with families who hadn't budgeted for this, and now they have a child with new onset diabetes, and it really changes their priorities for their finances. For our children who have public insurance, California Children's Services is a supplement to Medicaid, which covers a lot of the costs for children with diabetes. But one of the challenges with CCS, as we call it, is policies change. So we had CGM coverage for a while, but getting CGM for our publicly insured kids requires 4 glucose checks a day to get approved. And then coverage went away for a few months, and now it's back again. And what we've seen is kids who started CGM did really well. When the CGM got taken away, they did poorly, often worse than before they even started. And then when they get the CGM back, they don't go back to where they once were. And then one of the challenges with pediatrics, I think more so than adult, is that pediatric diabetes centers are really concentrated in academic centers in urban areas. So San Francisco, Los Angeles, San Diego, there's Children's Hospital in Madera, but other than that, it's really a pediatric desert. And so our families are often traveling great distances to come and see us. And video visits really has the opportunity to close that gap. And we've been doing video visits for a few years, but what we noticed was prior to COVID, we weren't having a lot of our minority patients or non-English speaking patients participating. With COVID, we've closed a lot of those gaps, but we've really been helped out by the fact that many of these families are provided internet access by their schools. And so while video visits really does help to bridge some of these barriers we had, the internet barrier is going to be really big in the post-COVID world.
Yeah, and I don't know, Gary, since you're working on the national level and regarding health inequities, is this something that is similar in other states, or, on a national level, is California similar, different, both?
Oh, the problem is we have no national plan around diabetes.
Yeah.
When we started collecting data, 3% of the American population had diabetes. It's now over 9%. In the Medicare program, it's going over 20%. 38% of the Medicare budget is spent on people with an underlying condition of diabetes, and they're all going to the hospital, right? We need warp speed in diabetes. In the same way that we decided that we were going to address the coronavirus or HIV or hepatitis C, I think the moment's come with diabetes that we've got to bring this disease under control. It is very, very costly. It is destroying lives, and we're not doing anything about it. We have an acute care system where basically we let around people who cook in their sugar, go to the hospital, and cost a lot of money. And really, at the end of the day, we elevate their mortality rate. That's not a healthcare system.
Yeah, it seems that the rate of diabetes in the US has seen a 35% increase in the last 20 years. And, the other big problem here, not with pediatrics, but with adults, is it's estimated that almost half of adults either have prediabetes or are undiagnosed in the state of California. And I don't know, I know, Dr. Edelman, I know you work with adults. I don't know if you guys are seeing an increase or decrease in people coming to see you or getting diagnosed. Has anything changed with COVID?
Yeah, you know what? Marissa, you're making some good points that, as you know, pre-diabetes or people at risk, there's no symptoms. And that's a very dangerous situation. Any condition where there's no symptoms, doesn't lead people to get medical care. So, and I can tell you, the primary care doctors, they're so slammed and busy, they're not even thinking that direction. That's why I think public education is important, letting people know that, if you have a first or second degree relative with type 2, it doesn't take a rocket scientist to say, hey, I wonder if I'm at risk. But type 2 is a tough condition, and I can say for sure we're seeing more and more people with type 2 diabetes, despite all of our efforts based on private industry, government programs. The rate of type 2 is just skyrocketing, and in our kids. Priya's probably has a clinic for young kids with type 2. We do in San Diego, and what do they have in common? They have parents with type 2, their problems with their weight, and many of them are members of an ethnic group hit hard by type 2. So this epidemic is not slowing down. And then you can bring in the COVID situation, and they're definitely more at risk for a more serious outcome. And even I think the best data that I've seen equates the A1C, the glucose control, with outcomes. So whether you have type 1 or type 2, glucose control is important. And we know that, last thing I'll say, and I'll stop it, of people with type 1 diabetes, maybe 25, 30% are at a good glycemic goal level. Kids are even worse. We had to raise their A1C goal so that more of them could fit into that approval rate. And for people with type 2, the general population, the NHANES data shows 50% have an A1C. And then you go to HMO data, it's 40%. And Medicaid, 30% of type 2s have an adequate A1C. So it's a very tough condition to treat. People with type 2, as you know, they got a high propensity towards heart disease. We have so many new medications that can now lower glucose and prevent heart disease, but they're expensive and they're hard to get. So it's not a great situation, to be honest with you, And Priya's right. I mean, if you have good healthcare, you go to university, you get a good, well-trained diabetologist, and you get motivated, you could live a long and healthy life, and even longer than other people, believe it or not. But unfortunately, that's a minority.
Yeah, and something that you mentioned that has been on my mind a lot in this pandemic is the health disparities have really been thrust into the light because of COVID-19, which I think is sort of good in the way that now more people are paying attention and more people are listening, I hope. But Gary, I'm curious from your perspective, have you seen any sort of meaningful change or hope in the right direction regarding that? Because for diabetes, those disparities are the same from my understanding.
Yeah, we do a lot of talking about health disparities and eliminating health disparities. The Heckler report was done back in 1984. We had Healthy People 2010 that was going to eliminate health disparities by the year 2010. I mean, the conversation has been going on. The numbers have not really changed. Take CGM, for example. If you're an African American or Hispanic, you are not getting a CGM, right? I mean, the way the system is structured, you're not getting one. In the Medicaid program, you're not getting a CGM. You can barely get one in the Medicare program by the way they set the program up with the 4 strips of qualification and all of that. And those things save lives, right? I mean, that's you save lives by giving people the CGM, but we're still withholding it. And so when we have those kinds of disparities at the basic technology level of the ability to actually do something meaningful about health disparities is really problematic. And the thing about California that's very interesting, it is a majority minority state, right? The majority of the people in California are minority. It should be pioneering the way to providing quality care for diverse populations, teaching the whole country how to do that. And it's a real opportunity for California to lead the way for the rest of the country, and it ought to be encouraged to do that.
Yeah, and Priya, I don't know if you want to speak about the Nuance CGM program that you guys are doing at Stanford.
Yeah, so one of the programs we've been doing at Stanford for our patients with type 1 is to start them on CGM within the first month of diagnosis, with the goal of trying to improve control and have good learnings early in diabetes when people are the most engaged, and hopefully have that continue for the rest of their life with diabetes. And we've been running the program for about a year now, and we're seeing about a 1% difference between our historical group who did not get CGM and those who are getting CGM. plus remote monitoring. So that's frequent check-ins with the care team. When we first started the program, we actually had really struggled with our patients who were publicly insured, and many of them are minorities, just because of the challenges getting this cover through public insurance. We got some philanthropic funding to provide these devices for our patients, and that's really helped. And they've also experienced the benefits of this. But I do agree with Gary that our patients who are minority are being left behind. Many of them are predominantly on public insurance. In California, for children, the policies for technology varies from county to county. So if you live in Santa Clara County, where Stanford's located, you have you have a system where they're very supportive of technology and they're willing to flex on their rules to help get kids on technology. Whereas San Mateo County, which is just one county up north, it's a little bit more challenging. For example, one of our diabetes educators recently had a conversation that was frustrating for her, where we had a child publicly insured who has had 2 hospitalizations for diabetic ketoacidosis in the last year. And we were really trying to get him on the tandem system with Control IQ to help keep him out of the hospital, just because that system can help regulate glucoses. And the pushback we were getting from San Mateo County Healthcare was, well, he's been hospitalized twice. He's not a good candidate. And she spent the better part of Monday trying to get this covered for him, because this is something that will really make a difference.
Yeah, can I jump in there? My getting a CGM when you're first diagnosed after a month, my comment is, why wait a month? Think about it. If someone comes down with type 1, which is a lot more complicated than many type 2s, having it as soon as possible. And I know what you mean, Priya, you can't get people right away, but
oh no, we're getting them on within 10 days.
Yeah, that's awesome.
Yeah.
So think about, I don't care what age you are. I mean, us adults too, we need help. You get type 1 and all of a sudden someone says, oh, you got to take 4 or 5 shots a day. You got to figure out how much insulin to take. You might get high, you might get low. And then you got to start pricking your finger. And even if you prick it 6 times a day, you have no clue which direction it's going to and from. So I think that should be the standard of care. I'm glad you guys are doing the study. And also, I'm kind of disturbed to hear about how when patients get CG and then they go off and go back on. I'm not surprised. You kind of lose your momentum, and so I do think that CGM is also going to be a tremendous advance for people with type 2. Let's say if the world was a better place, we would get type 2s a CGM, these newer, more inexpensive, easy to use ones when they're pre-diabetic, for God's sake. Then they can start seeing what happens when they eat right, when they don't eat right, when they take their meds, when they don't take their meds. So I do think it's going to be the standard of care. It's just access. But to have these poor kids not have access, that's just not right,
Yeah, and we have a question from the audience that sort of ties into this, and part of this is getting the whole system in order, but the other part is getting the healthcare providers to utilize it and to prescribe it, coverage or not. And so, one of the questions was, I run a Medicare chronic care management and remote patient monitoring programs. And this person thought that during COVID, it would be easier to convince primary care providers to implement some remote patient monitoring for patients. And the question is, what am I missing? And I'm going to tee this one up. Whoever wants to answer it, what do you think is the biggest barrier for providers in implementing? I think Steve said something earlier about how busy they are, and that may be it.
Well, let me say one quick thing. I mean, we make primary care providers, they are really important group of doctors, but they are too inundated with stuff. Yeah. And you can't give them one extra thing because it's not going to work. So there has to be a system where they don't have to do extra work. And in fact, if someone helped them do it, they would realize how it saves them time and they can take better care of their patients without increasing the time burden. I don't think they're against it. I don't think they're stupid. I think that you just can't add one more thing. And that's why our healthcare system is broken, whether you COVID or pre-COVID, it's just not enough time. Priya, I'm sorry, I got you before you got to say that.
Okay. Thanks, Steve. Yeah, so we are doing a version of a remote monitoring program for our patients in the New Onset program, and we're currently doing it for about 100 patients. And our diabetes educators who are really behind the program are spending about 8 to 12 hours a week doing remote monitoring. And these are people, you know, where it's their full-time job to do diabetes care. And I think with primary care providers, if they're doing something similar, especially with the larger panels that you have in adult medicine, I think it's just finding the time to actually fit all of this in with your routine patient care, patient visits, plus dealing with all of the other challenges that everyone's experiencing with COVID right now.
And is there reimbursement, things like that too?
Yeah, I would jump in and say this because I think it's important. Healthcare is a deep collaboration. Yeah, providers are one piece of the puzzle, right? But if you have legislators who are setting up policies that deny access, or insurers who don't provide access, or people who vote upside down so that their neighbor don't get healthcare, because people always vote for themselves to get healthcare, but they're less concerned about whether their neighbor gets it or not. We all have a responsibility here. And when we understand that deep collaboration and how we have to work together in order to manage these diseases, then we'll start looking at real numbers. Guess what? 75% of all of the hospitalizations for diabetes are paid for by Medicare and Medicaid programs. They're coming out of the public trough, right? That's all of our tax dollars, because we're not managing diabetes in those programs. And it's incumbent upon us all as voters, putting pressure on our legislators, making sure that we get good quality in the health systems when people go in, so they're reducing risk, and we educate those who have diabetes appropriately how to manage and live with the disease. That's all of our responsibility to make sure that we get the best possible outcome for these patients.
Gary, you are so wise.
Yeah, I agree. The only thing I want to add before we close up is, you know, on the patient side, I think you should also be encouraged, if you're a person with diabetes, to advocate for yourself at your provider's office, at your legislative level. I mean, you know, I've been told no for things before, and you know, I've used my voice and said, well, okay, I'll find a different provider that's going to give me what I'm looking for. And I encourage you to feel empowered, because you deserve the care that everyone else is getting, and you deserve quality of life.
Yeah, and do it constructively. Take control of the diabetes, and I think, you know, squeaky wheel gets oiled, and a knowledgeable patient knows what to ask for. So yeah.
Public education, again, it's huge. It's huge. And we are at time, and I believe that the team is going to jump on, and I just want to thank you all for your time and for sharing the lessons that you've learned, and I appreciate all that you're doing.
Thanks, Marissa. Thanks.
Thank you very much. Enjoyed it.
Gary, good seeing you.
Yeah, good seeing you again.
I get all your emails, so
what's fun. Thanks.
Oh, there she is.
Thank you guys so much. Thanks everybody. And panelists, if you'd like to stick around for more of the presentation, if you could just turn off your cameras and mute your mics, that would be perfect. Thank you so much for that discussion, which sets us up perfectly for the next part of our discussion, because now that we are grounded in what diabetes looks like in California, we can shift into what government looks like in California. So this slide shows your congressional delegation. California has 53 members in the House of Representatives, which of 435 total members is a huge amount, is 12%. If you're not sure who your representative is, you can use the link at the bottom of the page to find that information. You'll see here California Senator Feinstein and a blank spot for the seat formerly held by incoming Vice President Kamala Harris. Governor Newsom will nominate somebody to fill that seat in the coming days. And because this is focused on state legislature, we've got a quick overview for you. You can see here that you have Governor Newsom, the Assembly, and the Senate, all led by Democrats. And again, you can use the link at the bottom to find your member if you aren't sure who it is. In California, legislators convene for what is called the legislative session, which begins the first Monday of December and even numbered years. So a new session has just begun as of last week, and it lasts 2 years until November of 2022. Senators are reelected every 4 years and assembly members every 2 years. And interestingly, California is one of 15 states with term limits. So if you are elected after 2012, you can serve for 12 years total in your lifetime. So you can spend 12 years in the assembly, you can split them between the assembly and the Senate, but you have a dozen years total of service. Democrats do have super majorities in each chamber. So if the governor were to veto a bill, the assembly and the Senate could have 2/3 of the votes needed to override with just a straight party line vote. So veto override requires 54 votes in the assembly and 27 votes in the Senate. And you can see here, Democrats control all 3 chambers. There is often agreement on many issues, but not always. But that does mean that if a bill is sponsored by a Republican, it's going to need some Democrats to support it, since you need a majority of votes to pass. And we say this so you can actually, when you look up a bill, you can gauge its chance of passing. You can see where it is in the process. You can check out who the sponsor is and who else is supportive of the bill. And speaking of where it is in the process, that takes it to our next slide, which is how a bill becomes a law. There's an image here. Bill from Schoolhouse Rock is one I've noticed has 100% chance of making people smile. And usually someone starts to hum the song too. In that song, Bill actually notes that he's one of the lucky ones, that most bills never get as far as he's gotten, and that's true. Over 14,000 bills and resolutions have been filed in Congress since January, and 90% of them have received no action. So no committee hearing, no vote. Congress is split, which causes it to move more slowly, but it's also designed to move slowly. And that's the really exciting thing about state legislatures, is there is a lot more action on the state front. Here you'll see all the steps to the journey of a bill, from when it's filed to when it's signed into law, and action is required each time you see those colored boxes shift. And what's important to note here is that each color shift also represents a time when advocates can use their voices to actually make a difference in the process, to influence it. At the start, advocates can encourage legislators to file a bill. Once a bill is filed, it gets assigned to a committee based on the subject matter. And the bill could never move again after that. So sometimes we call on advocates to contact committee members to ask that they bring the bill to a vote and vote yes or no, because they are more inclined to do so if the community weighs in. So sometimes we're actually able to bring advocates into the committee hearing to testify and tell their story on behalf of the bill. And that's another way that we get champions involved. If a bill passes out of committee, now there is more advocacy that's needed to make sure that the full chamber will vote and pass the legislation. We ask advocates at this stage to write their representatives to ask them to vote yes, or it could be the opposite for a bill that we are opposing, to vote no. And then the bill starts the process again in the other chamber. So it begins again in committee for a floor vote, and then lastly, the governor gets it. We can either appeal to the governor to sign it or to veto it. So there are lots of moments where hearing from you, hearing from the people back home, the constituent, makes a major impact in the process. And DPAC will help you find ways to use your voice when it matters most, and we'll get to that later on. Now I'd like to switch gears though and introduce our moderator for our legislative speaker. Bob is the managing partner at Babbage Co-Founder, a government affairs firm based in Kentucky and Washington, D.C., and has been an advocate for diabetes for over 20 years. Bills he's worked on in the State House include several that have become national models copied by other states, including the first ever Diabetes Action Plan and the first bill to establish licensure for diabetes educators. Bob served in elected office as Kentucky's state auditor and Secretary of State, and we do share a last name. He is my father, and diabetes is a family passion and cause of ours. So thank you for joining us, and I will turn it over to you.
Great. Make sure I'm on here. Well, let me introduce an outstanding member of the Assembly, a name to know and a leader to remember. Adrian Nazarian was elected in 2012. He serves from the area of Northern LA. He's a UCLA grad. Importantly, he chairs the Committee on Aging and Long-Term Care. He also serves on health, budget, and transportation, 3 different areas, for a rather breathtaking portfolio of public policy. I would recommend you read his family story, a century plus of incredible resolve and determination and inspiration to me and to many, I'm sure. He comes to us as a tremendous champion for diabetes issues. We appreciate your role and your work, and it's a privilege to welcome you to a cheering crowd that you can't quite hear.
Good afternoon there. Thank you for having me on.
Glad to have you. We think everyone has a diabetes connection or a diabetes story, and would certainly ask that you take a moment to share yours and why you are working as you are on this issue that is a cause all of us are committed to.
Well, thank you. First of all, thank you for having me on. Diabetes is something that has multiple points of intersection for me. First of all, I grew up with some of my dearest and closest friends being impacted by that, by diabetes, and just growing up watching them have to go through the process of self-medication and or self-gauging was a very interesting experience, since I never had to do any of that. I could enjoy being a kid. Meanwhile, I had these friends who had to become very responsible very early in their lives, and to maintain a continuous level of awareness about themselves. I thought that was all, growing up, I thought that was very interesting. So I had an appreciation for friends, and then within family, I've had the issue as well, especially among my extended family members. And in the community, I see it far too often, especially within the working class communities. Anywhere where you see that people may not be getting good nutrition uh, due to desert communities that don't have appropriate groceries or food, nutritious food being provided, or the local 7-Eleven is the main source of nutrition in certain communities, to poor hubs of poorer communities where you'll have the parents working at 2 to 3 different jobs and not really paying attention. Nutrition becomes a tertiary level of issue. You first and foremost want to make sure that there's even food on the table, even if it's bread or pasta or something that's just a continuous source of only certain type of nutrition. I grew up in LA, so I grew up in Canoga Park, Winnetka communities, very immigrant-based communities, and for the ever since college, I've been living in the East San Fernando Valley area. For those of you that are familiar, which is the Studio City, Valley Village communities that I now have the honor of representing. So, having a very diverse area also, and seeing how people live, and so much of it being socioeconomically driven, because I will humor folks and let them know that I live blocks away from George Clooney when he's in LA, 3-4 months out of the year in Studio City, and a few blocks just away from him is maybe a single bedroom apartment with 2 or 3 shared by 2 or 3 families. And these are the circumstances in LA, and I believe in most dense hubs that are extremely expensive to live, and not only for rent purposes, but the living standard requirements are expensive, and so food and nutrition become an issue. So it's this conglomeration of effects of that shape my view on diabetes, how it impacts us, and how it is as much of an argument there is among scientists of to what extent it's genetic, to what extent it's something based on environment. The reality is that both have a significant role. And when you look at individuals being born with traits that will lead to this, it's always very frustrating to know that we as government aren't doing enough to make sure that there isn't a genetic, what I dub to be a genetic monopoly for drug manufacturers and or drug basically providers, whether it's the insurance companies or the drug manufacturers, to provide these life-saving medication at a level where everyone can afford. So,
outstanding introduction, sir. Share with us, if you would, what you've worked on before and what you're working on now in order to get results for people with diabetes up and down the state.
sure, sure. By the way, as a form of background, I've been a staffer for the better part of my career. I
Yes,
worked
sir.
for four different elected officials, and I honestly never really thought I was going to run for office. And I'm not saying that to be overly humble. That's because having worked for four different electeds, I see how challenging life can be for electeds sometimes. So I enjoyed my privacy and my time with family. So I don't know what my wife had put in the water when we decided that we were going to do this, but it was a family decision. And when I took office since 2012, I wanted to be on health committee. It wasn't an area that I had had a lot of experience in. I had been a staffer during my years as a staffer. I primarily worked on infrastructure related issues, water, transportation. Those were areas that were so vital and so critical to the needs of a large place like LA. If we want to be sustainable, those are the two foundational issue areas that you think about, and of course housing now because of the homelessness. But to me, healthcare, given that the ACA had just passed and the states were going to be implementing it in 2012, I thought, what a great opportunity. If I'm going to have the opportunity to potentially serve for a total of 12 years in the state legislature, I can help tweak and shape this arena quite a bit and be able to extend healthcare as far and wide as possible and make it accessible. So since my first bill on diabetes as a health committee member as well was in 2015 when I introduced AB 270 that primarily focused on a DMV driver's license. I'm sorry, a DMV license plate. Because you need to get a certain number of signatures. You need legislation to allow that to happen. You collect the signatures, and then whoever wants to customize their license plate, they can get a diabetes specialty license plate. That way, it generates a certain amount of revenue annually, also to go towards diabetes education, study, and research programs. So that was kind of my foray into doing a work in diabetes arena, because I always feel that it's important to look at generating revenue towards some of the programs that you want to implement. Then after that, I not directly on diabetes, but when you look at nutrition, especially nutrition provided in schools, and you see what percentage of students are actually dependent on school provided nutrition and food. I introduced AB 479 in 2019 that would target basically K through 12 schools, class grades in public schools, and provide the option of plant-based meals for students. Part of our history as just human beings is that we always fight certain things, we fight change, but then when you introduce it, you create a little market space, and then you allow for people to be, people's ingenuity to take over, and so they take plant-based meals and make it into very tasty meals that attracts even the most carnivorous amongst us to enjoy it. And I may have shared this with Bob as well in the past, but I growing up in Iran, my mother would make a lot of the Iranian meals. Although I'm Armenian, a lot of the Armenian meals are very heavily herb and plant-based meals. And the amount of meat or any type of meat that you would have are very small portions. So it was just always very balanced. And of course, as a 7, 8-year-old, you don't think about this, but as you get older, you realize what an advantage you've had being exposed to these meals. And so I thought it was critical for us to make sure that we're introducing this option into our public schools so that not only are kids having a healthier diet, but they're just learning about these options at a younger age, thinking about them, having their parents think about them. And it's just a change in the lifestyle and the greater awareness. Um, I don't want to belabor the point, but something I've worked on since pretty much my first term in office has been taxing sugary drinks. I've never introduced a bill, but I've always been a co-author of any of the bills introduced. And so we've worked on that for some time. Unfortunately, it hasn't been successful, but when you look at the direct correlation of sugary drinks and its impacts on diabetes and children especially, it's something that we're gonna need to address, and we're gonna need to pass that legislation. And then in 2017 I was a co-author of the the continuous glucose monitoring program through Medi-Cal, and just last year was this year was AB 2203, which was the placing a limit on the cost of insulin per month period, per a 30-day period. So in summary, it's kind of wanted to give you a little bit of a taste of all the different legislation, because that kind of also gives a sense of how it's not just about diabetes, it's everything that also leads to a quality life and healthier upbringing and attitude.
I'll come back to this in a moment, because we have many participants who are letting Julie know they want to help you with the CAP bill as it comes back around. But we're seeing from COVID, one thing's clear, that it's disproportionately impacting people, a segment of our population. We constantly hear about health inequity. How can California be the leader here? How can we work with you on that?
How can we not? How can we afford?
I think we moved on.
My apologies for that. It's my kid's piano teacher calling because they're doing it online. So uh, I thought it was going to be a little later. Well, how can we not afford to do this? I mean, first of all, you look at California and the market that we represent. You look at the needs of the diversity and population that we have. You look at how socioeconomically we're becoming such a disparate state. You have the tech industry and you have the entertainment industry, whether in Northern or Southern California's respective. Sorry, folks. Can you hear me?
Yes, sir.
Okay. So you have these extreme wealthy hubs, and then you have a lot of folks that, we've had a lot of folks migrating to the state. We have a very large sector of service employees. And so we need to make sure that we're providing the best healthcare outcomes and opportunities for all Californians. And when you look at these issues, by the way, I know that they sound great and they even sound altruistic, but the reality is that they also have long-term cost impacts on the state. We start looking at nutrition, and some of the ranchers and cattlemen association folks were kind of upset with my bill last year with on the plant-based meal. And I explained to them, I said, look, I myself am not a vegetarian nor a vegan. But I do believe in a balanced diet, and we don't do enough to expose our children to that. When they're bombarded with advertising, they don't see, the benefits of salad, and so you need to start someplace. So I'm not working against the interests of ranchers, I'm looking at how do you provide a better balanced meal. And so, you know, the issue again to this question is how do we provide a better, you know, balance so that the state also has limited long-term healthcare costs. You know, healthcare, we spend $400 billion in the state of California on healthcare alone. Most of that is federal money, but the portion of it that the state spends takes up a quarter of the state's budget. And that's only going to be growing over the years if we don't address some of the long-term healthcare issues that we're facing right now.
Two quick questions. What would the CAP bill accomplish? That's what our audience and our group tonight wants to know.
So the CAP bill was very straightforward bill. Since we've seen since the early 2000s the cost of insulin rise by, in some cases, up to about triple the amount. I mean, there's some awful statistics where between 2003 and 2013, among one or two of the manufacturers of insulin, so when you look at that, sorry, now my wife is trying to get a hold of me. So when you look at these impacts, what this bill did was very straightforward, say, for one vial of insulin per a 30-day period, you will not pay more than $50 a month. That's it. If you need to use more than one vial, or if you need to use multiple, your cost will not be more than $100 per month. And I had worked with the ADA on introducing this bill, and the California Health Trust as well, and several other wonderful partners late last year, prior to any of the COVID-related issues bursting into the scene. So when the issue of the pandemic hit, it just was extremely an appropriate opportunity to make sure that a community that is going to be disproportionately impacted by this disease get the benefit of this lower cost, so that none of the rationing nor any other issues or costs associated with insulin are a direct impact on patients ending up in hospital and becoming more susceptible to COVID.
Well, you got to the 50-yard line. We'll give you great credit for that. Now, the Senate didn't move as your chamber did. Why did that happen? And in conclusion, you have a standing army here to help you. How can we help you most? Two-part question.
Thank you.
Why the failure, and how do we help?
I'd love to have you partner with me, because I am talking to our partners from last year to see if we want to move forward again this year. It was held up in Senate Health Committee, and ironically, excuse me, the Senate actually in California tends to be the more progressive of the two bodies between the Assembly and the Senate. So I was shocked to see that it was held. And with every which opportunity, I tried to address this with the Senate Health Committee Chair, Dr. Richard Pan. He did not want to move it forward. He was interested in advancing his bill, which was a more, his approach is to make sure that multiple medications are reduced in their price so that there's more medication available. And my explanation to him was, well, you know, several other states have already done this. This is something easy we can accomplish and do. And when you look at how 40% of those impacted by COVID are folks who are diabetic, this will be an immediate direct relief. These arguments, unfortunately, didn't convince him. So I'm hoping that with your efforts and your support and more engagement and broader media attention to this issue, we can make sure that we are able to succeed and get his attention on this and pass this bill forward, because it is very timely. Even if it's for the next few years, And so it allows for there to be a relief valve during this period of the pandemic before everyone is vaccinated, or as many people are vaccinated as possible.
Well, Assemblymember Adrin Nazarian, we are very impressed with your work, with your commitment, and thank you from all of us for joining tonight. And good luck with
Thank
the
you
piano
all.
lessons.
Thank you
Best
so
to
much,
you.
Bob. Thank you all. Look forward to partnering with you. Take care.
Thank you.
Perfect. Thank you so much, Bob and Assemblymember Nazarian. It was wonderful to have a member of the legislature on with us. And if we can shift gears now into the next part of our presentation, really great to hear that we can be a partner and continue to work with Assemblymember on the copay cap and on other legislation. We had a lot of questions, a lot of ideas, a lot of really good points from our audience members. A few of you made the point that it's not just insulin, that there is more that must be done for access to affordable care and management, to technology, to education, to providers. Those are all issues that DPAC works on, and we're really excited to address those as well in some of the later segments of our presentation. Rather than just tell you about these folks, though, I'm going to let you hear from one, and it's Ed. His card is right there on the left middle of your screen, Edward. And he can come back on the line and turn on his camera to briefly tell us his story and to share what being a diabetes advocate in California looks like. So rather than just tell you a bunch about the champions, let's have you talk to a real live one. Ed has done so much for diabetes. He was a past chair of the board for the American Diabetes Association and recognized by the ADA with the Charles H. Best Medal for Leadership and Service. So a champion for people with diabetes for decades. Ed is actively involved in the state of California, where he resides with his family. And we'll bring him back on here to talk to us a little bit more about his advocacy. So Ed, can we start just briefly with why people are often asked, why do you advocate? And we know that that everyone has a connection. Could you tell us yours?
Well, I think in my introduction, when I had mentioned that it sort of feels good to do good for others, and I think advocacy falls in that way as a way of making a difference. And through my involvement with the DLC and DPAC, I've been interested in how we engage policymakers, public and private sector influencers to call attention to the diabetes epidemic and provide a voice for over 30 million Americans living with the disease. And we are continue to be committed to reducing insulin and device costs across the United States. And also, I would say that it's also very encouraging to see policymakers paying attention to the problem, and especially like the passionate Assemblyman Nazarian. But the
Definitely.
problem is that policy changes take time, and many people with diabetes are still struggling to not only afford things like continuous glucose monitors, but life-saving insulin today. And diabetes doesn't discriminate. And however, our minority communities have been disproportionately affected, especially with regards to CGM access.
Yeah, and I know that's an issue you've worked on. Can you tell us some about that issue and others that you have been working on in the state of California?
I can. I was fortunate enough to work with Larry Ellison on the safe needle disposal, and that was really interesting because it focused on how to dispose used sharps, because disposal rules and regulations across states and localities is very different. And so it's as important for people with diabetes to know how to administer their medications at home, work, or whether they're traveling, but it is also equally important for them to have a plan for safely disposing of their used sharps. Most recently, we've been able to, with a coalition of other organizations, to work on Medi-Cal coverage for continuous glucose monitors in partnership with over 20 different diabetes organizations. So if you're on and you're one of these, I want to thank you very much for participating. I hope you can see that. California's minority communities are disproportionately impacted by coronavirus, with early state statistics reporting COVID-19 fatalities as double their percentage of the general population. So since many Medi-Cal members are members of our minority communities, The question is, does it make sense to withhold critical access from those who run the highest risk with significantly higher diabetes and COVID-19 risk among ethnic minorities? The other issue is the lack of Medi-Cal access creates a two-tier system where private insurance patients have access to CGMs and Medi-Cal adult patients do not. So eliminating healthcare inequities ensures that patients receive treatment based on their condition and not on their bank accounts.
That's great.
So I just wanted to mention real quickly 4 points that we emphasized in that work, and one was improving patient outcomes. The second was protecting the economically disadvantaged and minority populations. And the third was eliminating health inequities, and the fourth was reducing the strain on our healthcare systems.
Perfect. Thank you for mentioning all those. And I think we have a few folks who are not from California on the call today, and you referenced Medi-Cal. I just wanted to make it clear that CGM coverage, continuous glucose monitor coverage in Medi-Cal is the state's Medicaid program. So thank you for your work on that issue. And it's one we'll cover a little bit later, but if you're a child in Medi-Cal, you can potentially find coverage for your CGM, but once you turn 21, it sounds like what you're saying is you're not able to be covered by the state's Medicaid system anymore, as if your diabetes magically disappears, right?
Yes, exactly.
Right. Thank you. Thanks for all the work that you're doing. And I'm curious, because you said that it takes such a long time sometimes to see the fruits of your labor, have you seen advocacy make a difference in outcomes for people with diabetes and in what actually gets done?
Actually, over the years, I've seen lots of progress made. And clearly, if you are a person with diabetes, that progress is still slow and not fast enough. But I think that where we have an opportunity as advocates is every interaction, whether it be a letter, an email, or a conversation, is an opportunity for us to move the dial for people with diabetes. And as I said earlier, it's encouraging to see that policymakers are paying attention to the problem, and that's because of the strong work and the advocacy work done by organizations like DPAC.
Thank you so much. Any advice, just a last question here, advice for first time or new advocates on the line with us today?
I would say you can make an immediate impact today, and you start by telling, as Julie said, 10 of your friends to sign up for DPAC, and that will help you spread the word and amplify the DPAC platform. Write letters to your elected officials, because a few letters can make a huge difference. And amplifying our voice is the most effective way to inspire and drive change. And I would say, 1, leverage your DPAC resources. 2, work to build partnerships. 3, stay connected and pick an issue that you are passionate about and be like a dog on a bone and never let it go. And whenever you feel unmotivated or like your motivation is waning, just repeat steps 1 through 3, because the passion of the DPAC membership is infectious. And whatever you do, don't give up, because unfortunately, this fight that we're in is a marathon and it's not a sprint.
Those are perfect words, a perfect example of a champion and how you could be involved and how you can stay involved. And I love that. Thank you for reminding everybody that as challenging as it can be, sometimes it's fun, sometimes things are moving quickly, sometimes, they're not. And so to really lean on this community and to stay involved and to not give up, those are all just great messages. So thank you so much, Ed. I really appreciate you coming back on the line to give everybody an example of advocacy in the state of California.
Well, thanks for having me.
Yeah, absolutely. Thank you so much for joining us today, and we'll be in touch very soon. If you have any questions, you can send them to info@diabetespac.org. We'll answer those. If your questions weren't answered today, we would love to hear from you. If you have any feedback, we would love to hear from you. And thank you so much. We hope you have a great rest of your evening. Thank you.